Hello, everybody, and welcome to Endoscopy Talks. I'm Christopher Chamness with Carl Stortz, and I'd like to thank you for joining us on behalf of Colorado State University's new Translational Medicine Institute. Today, we are joined by Dr. Wayne McIlwraith, a highly accomplished equine orthopedic surgeon who probably needs no introduction for most of you in the audience. Born in New Zealand, where he went to vet school before coming to North America, Dr. McIlwraith is most commonly associated with Colorado State University, where he has been a faculty member since 1979 and was also the founding director of the Orthopedic Research Center. Many of the early techniques in equine arthroscopic surgery were actually pioneered by Wayne, who has authored 6 textbooks, one of which is Diagnostic and Surgical Arthroscopy in the Horse, now in its 4th edition. In addition to his academic pursuits, Dr. McIlwraith also has a referral equine orthopedic surgical practice based in Southern California and is a consultant and surgeon for clients elsewhere in the US, as well as England, Ireland, France, and New Zealand. His professional interests focus on equine orthopedic surgery and translational joint surgery disease research, which eventually led to the creation of the Translational Medicine Institute at CSU, from where this Endoscopy Talks series is hosted. His list of credentials is much too long for me to cover in this short introduction, but a more complete listing can be found on the website of endoscopytalks.com. And with that, it is my great pleasure to introduce Wayne McIlwraith.
Okay, well, thanks for the introduction, Christopher. Christopher and I have known each other for a long time, been involved with a lot of arthroscopic surgery courses with Stortz. And the title today is Equine Arthroscopic Surgery. Welcome to the TMI. This is, in transparency, the equipment in this arthroscopic surgery course is Arthrex. Stortz have a large component of sponsorship within the TMI in the other topics of small animal, particularly small animal endoscopy and laparoscopy. But this is sort of a overview of what I've done, and a lot of it has involved Stortz in the past, and so we're still very much associated with it. Okay, so arthroscopy started for me with a research project in synovitis at Purdue. I went to, after an internship at Guelph, as Christopher said, I received my vet degree from New Zealand. I was in practice for 2.5 years. I then went overseas leading a climbing expedition in Peru, a New Zealand climbing expedition, and then finally decided I wanted to specialize in equine surgery, so I did an internship at Guelph. And when I went for my residency at Purdue, Jack Fessler gave me this project in equine synovitis. And so I thought it'd be a good idea if I could progressively look at this synovitis with an arthroscope. I'd read about the arthroscope. I'm frustrated because I can't remember where I read about it. Obviously, there was no internet then. This is 1975, 76. And I contacted Dr. Lanny Johnson, this gentleman here, who was giving a diagnostic arthroscopy course of the human knee. So it was, and I cheekily called him up and said, I'd like to come to your course. I'm a veterinary surgical resident. He said, I'd love to have you. I won't charge your registration. So it really started with Lanny having me up with 100 MDs, and we learned how to do a diagnostic arthroscopy of the human knee. They were scary days then. If you had medial knee pain, they commonly did an arthrotomy and took your meniscus out. So I tended to be holding my knee quite a bit when I was listening to all this in the audience. But it led to diagnostic arthroscopy, and I went back to Purdue and they bought me an arthroscope. It was actually a Wolf scope, the initial one I had, 2.7 millimeter, because I thought smaller was better. That's all changed. And I started doing arthroscopy diagnostically. And so really the further development of arthroscopy came. I did diagnostic arthroscopy for 3 years at Purdue, and looked at a lot of standard bred carpal joints because Chicago is only 80 miles away. And then I came to CSU, and that was when I got together with Simon Turner, and together with some of my early residents, including Alan Nixon here, we started doing arthroscopic surgery. And so By 80, we were doing clinical cases, 1980, and in 81, I started getting asked to do surgery elsewhere because I was the only one doing it. So there's really a combination of development of techniques at Colorado State University with other faculty and residents, and then outside at CSU, particularly at Equine Medical Center in Cyprus, that here where the photo up here is me doing arthroscopic surgery. This is the real thing. And as you can see, we're looking through the scope. And this was at Los Alamitos. Dr. Nancy Goodman invited me down and to do surgery. And it was made for the quarter horse who had multiple joint problems, multiple chip fragments in the joint. So this led to publications, textbook. There's 4 editions of the textbook, and courses, which we started at CSU in 1983. So really, there's an evolving process of sophistication and documentation to this story, similar to human orthopedics, osteochondral fragmentation, internal fixation under arthroscopic visualization, as well as the treatment of soft tissue injuries, including meniscal tears. And we'll talk about each of these as we go through. Arthroscopic surgery revolutionized equine orthopedics as it did human orthopedics. It allowed us to bring many equine athletes back to the same level of previous performance. Prior to that time, fragments were removed with arthrotomy, and usually the performance of the horse, no matter what the athletic pursuit, would drop. So it was sort of a combination. My veterinary peers, they picked up on it fairly quickly. As far as arthroscopic surgery being something different. There was skepticism in the community, but this horse on the left, Spenderbuck, winning the Kentucky Derby 5 months after I'd done arthroscopic surgery on his knee in Miami, changed things as far as what it could do. First down dash, this is an interesting case, but it's very typical of quarter horses. We did 6 joints on him at the same time for fragmentation, 4 carpal joints, 2 fetlock joints, and that's him winning the Champion of Champions, which is the big race at the end of the year for older racing quarter horses. But it really started with diagnostic arthroscopy, and diagnostic arthroscopy is still a huge part of therapeutic arthroscopy, if you will. These are just examples of synovitis on the left, and acute synovitis, and more chronic synovitis. And the third slide from the left is a erosion on the sesamoid bone in association with a displaced condylar fracture. We use this as a diagnostic basis, as a prognostic test. This horse is not going to race again satisfactorily when it's got this amount of erosion. So we've saved the horse, but and we'll talk about that later. And then the right-hand slide on the bottom is a meniscal tear, and it certainly revolutionized what we could do with those. As far as instrumentation, we were faced with, when I first went to that course, and as myself and other colleagues developed techniques, we could certainly use the human sold arthroscopes, but some of the other instrumentation required innovation. This is just a normal layout of arthroscopy instruments. A lot of them are conventional things like curettes, blunt probes. Ferrous Smithron durs were the workhorse for us because all of the human grasping forceps were very fragile, at least for taking chunks of bone out, which they didn't have the osteochondral fragmentation in human that we do in the horse. And so initially we did arthroscopy directly like this. Obviously, you had to be careful for preserving aseptic technique. I did this for a number of years. This picture on the right shows us doing it without cameras. And then the early cameras were very problematical. And so this was the way we had to teach the courses as well. We'd be looking through the scope and then handing over or handing back to the delegates who were learning the techniques. And of course, there's been a great evolution of video cameras and capture systems. The technology is superb with what we have here. This is just a 3-chip camera on the left, the camera, and then a tower on the right. in the OR at the Orthopedic Research Center. The other advances were motorized pumps and motorized shavers were critical for both visualization and soft tissue surgical debridement. So the first phase of arthroscopy I like to call diagnostic arthroscopy. It was initially reported by 2 practitioners in Michigan in vet medicine small animal clinician, which was a nice colored picture book that was our favorite journal when we were in vet school, at least, because it was really simple and there were lots of pictures. It's now defunct. The first detailed paper was done by myself and Jack Fessler, doing diagnostic arthroscopy and defining different anatomy, because we had to relearn the anatomy of the joints. This is an example where a pure diagnostic arthroscopy of the carpus. This was a high-level Grand Prix jumper with middle carpal joint symptoms that blocked out, but there were no radiographic changes. It did light up on scintigraphy. And as you can see in here, if we go to the back of the carpal joint, we've not just got cartilage loss, but it's actually into the subchondral bone. And after debridement of this lesion, we did microfracture of the defect, which is a technique that was developed in people, but we validated in the horse as a way of stimulating repair of a cartilage defect. The point I wanted to make here with this video, and I'll have to figure out how it's going to work otherwise, is that we started doing diagnostic arthroscopy. We still do diagnostic arthroscopy. The still picture of this video is a fragment that I'll show a little bit later off the distal radial carpal bone. The first joint that we did a lot of arthroscopic surgery in was the carpal joint. And so this leads us into the second phase of surgical arthroscopy, that we started developing techniques. This is kind of an approximate order where we initially did a lot of arthroscopy in the carpus and the dorsal fetlock joint. These were the joints that most commonly we did arthroscopic surgery on in racehorses, and racehorses were a large part of the caseload. Then we developed techniques in the tarsocrural joint, femoropatellar joint, and shoulder, particularly in the tarsocrural and the femoropatellar joints. There was a lot of OCD that could be treated this way. And then as techniques were developed in the distal and proximal interphalangeal joint, the distal interphalangeal joint or coffin joint, the first description of removing fragments from the extensive process of P3 was described by Joseph Burning, who was a close colleague, and we did a lot of surgery courses in collaboration with Storz in Germany. He was also a very good artist. Unfortunately, he's deceased now. And this just sort of puts the picture in perspective of the joints that we gradually opened our armamentarium as to what joints we could do. So I'll try a video again. And this video shows arthroscopic treatment of an acute simple osteochondral fragment of the dorsodistal aspect of the radial carpal bone. To perform this surgery, the horse is in dorsal recumbency, and the arthroscopic approach is laterally between the common digital extensor and extensor carpi radialis tendons. So I'll go back to my own video, but this shows the fragment. We've made a medial portal. And so obviously triangulation was the key technique that came. And of course, it's been translated over into laparoscopy and other techniques, minimally invasive surgery techniques. But we always had to prioritize the instrument because our instruments are rigid. So this fragment is on the medial side, on the distal radial carpal bone. So our instrument portal is coming in medially, and our scope is laterally, obviously, with a wide field of view and an angled arthroscope. We've got a lot of versatility as far as visual field goes, but not as much visual field, not as much versatility, sorry, as when we're with a curette. And so here we are we've removed the fragment, and then we debride back to where there's healthy attached articular cartilage. We don't want to leave anything that's elevated. You can see the enlargement of lacunae in the center there, which is just part of the subchondral disease. subchondral bone disease, which precedes these osteochondral fragments. These are all pathologic fractures that occur secondary to subchondral bone disease, and that is associated with cyclic trauma, then egressing the debris from the joint. So just looking at the carpal chip fragmentation, because this was the one that we started doing a lot, we certainly learned a lot quickly. First of all, the amount of disease is poorly reflected by the radiograph. This is a radiograph of a fragment of the distal radial carpal bone. As you can see, there's a fragment, but there's also a lot of subchondral bone disease and cartilage erosion. Generally, we can often predict the amount of damage we're going to see by the degree of clinical signs rather than the degree of radiographic signs. And just another added beauty of the usefulness of the arthroscope. So we published our first 1,000 joints, carpal joints, we did in 1987. John Jovich and George Martin were both residents with me at the time. And we got a pretty high success rate of horses racing at a level equal to or better than pre-injury level. 11% had decreased performance or problems related to the carpus. There were 23 retired without returning to racing. Often this was after we'd fixed the horse. They decided that breeder in the case of a filly. But our success rate around 70% coming back at the same level was certainly highly acceptable and a total change in the degree of success we have. Some horses will chip again. I remember an interesting time of a person who didn't know that Nancy Goodman was married to me, describing how he'd had surgery and it didn't work well because the horse won 3 times and then chipped again. So you have to, communication is really critical with this so they know what's happening. The only reason we looked at collapsing slab fractures while racing, this was a problem in the racing quarter horse. And some people thought that if you did surgery for a chip fragment, you were predisposing that horse to more severe injuries. But anyway, those are the data. And we also looked at success rate relative to amount of damage in the joint. It was really interesting that some people were skeptical about arthroscopy, and they felt like, okay, it's going to work on a fresh chip, but if you've got cartilage damage at all, it's not going to work. So we arbitrarily made 4 grades of damage. This is grade 1, where we have very little articular cartilage change, just have a defect left from the fragment removal. Grade 2 was up to 30% of the articular surface damaged. Grade 3 was 50% or more visible loss of 50% or more visible articular cartilage. And grade 4 was when we had a significant loss of subchondral bone. So we lost the cuboidal bone support, and that was a worry. Now, just out of interest, this horse came back and won 3 grade 1 races after surgery, and this was the picture at the initial surgery. So a lot of the horses didn't read our papers, they didn't read the books. In other words, the horses got phenomenal pain tolerance, and some of these horses did really well. And grade 4, we did tend to get a higher incidence of return of fragmentation, but this is the success rate relative to the amount of damage. But you can see that even up to 30% articular cartilage loss from that bone did not affect the prognosis. So I'll stop there and invite any questions, Christopher.
First question is, to what specifically do you attribute not only the faster recovery, but the more complete recovery of racehorses having undergone arthroscopic surgery versus arthrotomy?
2 main things. There's less trauma. On an arthrotomy, if you look at the human situation where people can talk, they'd put you in a cast because they were concerned about healing. That would stiffen up your muscles, your quadriceps would seize up. There was a lot of morbidity associated with that. Certainly the soft tissue damage. I think probably more importantly, though, what I attribute it to is a complete examination of the joint. It's very rare that the radiographs tell the whole story. I've kind of already implied that, but we'd go into joints and we'd find fragments elsewhere. And if you think back to the days of arthrotomy, you do an arthrotomy that just is an over the chip fragment. So if it was a distal radial carpal chip, like I showed before, you do an arthrotomy over that and take it out. Whereas commonly when I go in a joint, that was the point I was going to make with the first video that didn't work, sorry, but we commonly find other fragmentation and other cartilage damage and other loose cartilage, for instance, that you can't see on radiographs. So that's the main thing, I think, is the complete examination, the fact that you deal with all the pathologic change in the joint.
Okay. And somebody asked, are Ferris Smiths still considered your workhorse?
Yes, they are. They're Ferris Smith intervertebral disc rongeurs. You know, in the early days, we just went through the instrument catalogs, and they are totally my workhorse. I have an ethmoid forceps that I use for getting small pieces out of doing dorsal P1 chips, and in some other joints, getting to the back of a joint. But basically, the Ferris Smith are definitely the workhorse. And you can get them in all sizes, obviously. Probably most of the audience is familiar with that, but you've got sizes, all sizes. I use 10 by 4 millimeter and 12 by 6 millimeter Ferris Smith rongeurs, straight ones. And that does everything for me except for large OCD fragments, particularly in the tarsocrural joint where I have a different large retriever. But that works well for me, those two types of Ferris Smith rongeurs. Well, I should say my 10 by 4 consists of one that's blunt ended and one that's got a low profile, more pointed ending. A more pointed ending, and I use that for proximal dorsal P1 chip fragments.
Okay, one more question for this break. I know you're doing work on stem cells. Can you make a brief comment on how this impacts your practice of arthroscopy?
Well, I think, you know, the main place, and I sort of had a slide at the end that I call phase 3 arthroscopy, the adjunctive treatments we've got. The main use where we use intra-articular, we use bone marrow derived cultured stem cells, and is in femorotibial joint injuries where we have meniscal tears, cartilage erosion, punctate cartilage erosion, and we've actually published on follow-up showing enhancement of our success rate with intra-articular MSCs. So that's the short version, but yes, we think we've made a significant difference. And so I've started using, depending on the horse and their timeline and how much money they're prepared to spend for optimal results, using them post-operatively in other conditions in addition to femorotibial joint injuries.
Okay, that's all I have for now, Wayne. And I'd encourage everybody again to please send in your questions. Thank you.
This is moving on to the second joint that we achieved sort of routine ability in was the fetlock joint, the dorsal pouch. You know, it's interesting, just as a comment, you know, we started with the carpus because it was easy to put the scope in. And, you know, I think I was always very tolerant of people who were skeptical, because I was skeptical at the beginning that we were going to be able to put a scope in and an instrument in all these joints. And actually, embarrassingly, I said that in a textbook chapter that I wrote for a very old textbook. So it's not around anymore, Equine Medicine and Surgery. It was the second edition. But I said that I thought that arthroscopy was great for diagnosis, but that the surgical potential was limited. So at least I proved myself wrong. But yeah, it's, you know, the thing is, this is a great demonstration, you know, that you distend the joint with fluid. You can go in, this is going in the proximal lateral aspect of the dorsal pouch, putting the scope in. This is using a needle to create your optimal site for putting your instrument in, going ahead and egressing to get a clear view, then elevating the fragment, taking the fragment out with Ferris Smith rongeurs. So this was a very common fragment, particularly in racing thoroughbreds, but quite a bit in racing quarter horses. And we certainly see a fair share of them in warm blood sport horses. But we used to think, this is another good example of the lack of diagnosis, that one of those last questions that Christopher relayed was, most of the time we always thought that chip fragments off proximal dorsal aspect of P1 were on the medial eminence. And that was because we did an arthrotomy and took it out. And we often could not see a fragment on the lateral eminence, which is not uncommon. So this is just another example. We go in the joint, then we make a decision. This is in the lateral eminence. We're not going to get an instrument from the medial side over to the lateral eminence. So we operate this one first. This is after removal of the fragment and debridement. This is the lateral condyle of the metacarpus. Then we go in and look over medially, and this is a larger fragment. This was the one that showed up on the radiographs, and then we elevate that and debride it. And this was a follow-up study we did, published in '94. Chris Kauchak was a resident and looked at all the cases that I'd done. We looked at 286 horses, 208 we got follow-up on. I'm sorry, 286 we got follow-up on. There was 336 horses, sorry. But anyway, you can see there that 208 returned to previous use, 153 at the same level, 55 at the lower level, 18 had refragmented, got another fragment, 60 did not return to previous use. But we're talking a greater than 70% prognosis, which was nice. And so I'm going to travel through a few of the other joints here. This is the tarsocrural or tibia tarsal joint. That was sort of like joint 3 that we got some expertise at. Again, we look at the anatomy. The scope goes over the top of the medial trochlear ridge because you can't get an instrument over the medial trochlear ridge of the talus, which is bigger. Instrument in laterally. And in most of the cases we operate, obviously, I'm not going through each one, but this is the most common location on the distal intermediate ridge of the tibia. So we put the scope in medially, the instrument laterally. This is a needle, making sure we got our instrument portal with the right angle, because we've always got to consider we don't just have to get touching it. We need to be able to do the maneuvers, particularly with elevation and curetting, to bring the fragment out, take it into the forceps, pull it out, and then a real trap for young players is you're not done then. You've got to very carefully look at this defect, and your angles where your scope and that is make it a little tricky. That there's often there's nearly always osteochondrotic tissue in the defect that still needs to come out. So that's elevating that until you got back and you've got a really clean defect and you can see the articular cartilage there. So a lot of success with this condition. We get OCD fragments in 4 different locations in the hock. Distal intermediate ridge of the tibia is the most common. And our overall prognosis for soundness is great, as well as, and we've published this too, and we've got individual figures if anybody wants the publications. They're actually all in the diagnostic arthroscopy book, but yeah, we've got very good prognosis athletically with all degrees or all locations. And we did show that our synovial fusion resolution is a little bit less for medial malleolus and lateral trochlear ridge of talus compared to the distal intermediate ridge of the tibia. Of course, it was a real boon for the femoropatellar joint, which is where we developed techniques later. OCD most commonly occurs on the lateral trochlear ridge of the femur. These are the techniques, the scope in between the middle and lateral patellar ligament, the instrument in laterally. And what we're doing here is this is an arthroscopic video showing elevation of an OCD flap. If the flap's loose, you'll have clinical signs. If you've got synovial effusion, you're gonna need surgery. On the other hand, if you don't have synovial effusion, you need to be carefully evaluate the case because there's quite a lot shows up on routine radiographs. So after removal of the flap, then we get to debriding the defect. It's quite soft bone there. The cartilage is quite thick in this location. And I started using the burr a lot when it first became available, but I actually tend to do most of my debridement of these lesions with a curette because I'm more sensitive to how it feels. And you can see the crappy bone underneath that still needs to be removed. Now, the palmar pouch of the fetlock's got some more challenging things to operate. Certainly, this came quite a bit later than doing proximal dorsal P1 fragments. And there's other conditions in the dorsal pouch that we did, but I'm passing over those. And so in the fetlock, this was our first joint where we really encountered the need to do sharp dissection with arthroscopy or under arthroscopic visualization. And of course, the things that we're operating there are fragments to the sesamoid bones, which occur they can occur on the apex. They also occur on the abaxial area of the sesamoid down here, and they also occur at the base of the sesamoid bone. The other main indication for arthroscopy in the palmar pouch is palmar plantar P1 fragments, and I'm going to show you an example of that. This is really hot off the press, but it was a bit of a challenging case that I had on the weekend. I actually operated this 10-year-old warm blood show hunter, had been a very successful show hunter, had developed a problem. Soft tissue swelling is associated with a suspensory desmitis that it's been treated for a while. And then this plantar P1 fragment of the proximal plantar aspect that usually we're operating when the horse is younger than this, but this had obviously become loose because it was a clinical problem, and the vet had, the referring veterinarian had confirmed that. So these are, so you're getting this one. This is just a DP view where you can see it goes quite deeply, deeper than most of these fragments. So this is, when I put the scope in and we're looking at the base of the sesamoid here, and I wanted to use this as an example as to the usefulness of synovial resection. It's phenomenal because we're down there, the fragment is down here, but I've actually got to debride the soft tissue away to clearly delineate the fragment. When I first went in there, it was all soft tissue, and you can see how the fragment's becoming visible here. This is the distal palmar metacarpus. And so what I'm doing is vacuuming, we've got suction on the end of the resector as well. So we're getting rid of the synovial membrane so that we can then go and do some soft tissue dissection. Sorry. And so this is a video of the maneuvers. These are certainly more advanced than the other procedures I've shown you so far, because I use there's a lot of very fancy knives that are quite brittle and they're disposable, but they're also very fragile. And you don't really want to lose a blade in this soft tissue at the palmar aspect of the joint or the plantar aspect. And so what I'm doing here is I actually use a tenotomy knife. I call it a sesamoid knife, but it's strong because it's not easy to get around this bone, and you've got to do sharp dissection of the fragment. And this is just showing that again. And then here we're removing one of the fragments, but we've got to sharply dissect it sufficiently so we can get the forceps underneath. Now that got the first bit. And then we go back in and get the second piece of fragment. You can see it here. And then this is a video at the end of debriding the defect and making sure that we've completely removed that bone. So this is sort of a combination of technique. You've got to be able to bring your instrument under the base of the sesamoid. It's got to be in the perfect line. If you come in too high, then the sesamoid will stop you getting to the area that you're operating. This is the proximal plantar aspect of P2 here. Sorry, of P1. Now, I'm going to talk about internal fixation, introduce that topic, carpal slab fractures and distal metacarpal metatarsal condylar fractures are the main ones we talk about. And these are the first description of operating a third carpal bone slab fracture in the radial facet was done by Dean Richardson at Pennsylvania. And that is still the technique we use. It's a great technique. And so this is taken from the arthroscopy book, obviously. You know, I think when Dean first described it, he had a single needle coming across the slab. I tend to sort of cover myself by having a 18 gauge needle in lateral and medial. And then we take a spinal needle so it comes across the slab. It doesn't have to be in the perfect position because we're going to monitor it with a skyline radiograph. We bring the spinal needle in and lodge it in this fossa where the medial palmar intercarpal ligament is. So what we're doing is that we're getting our lateral medial dimensions through our arthroscopic placement of needles. And then our radiographs, both a flexed lateral and a skyline, are going to tell us where we need to put the screw. So after that, it's back to AO principles. I usually use a 4.5 millimeter screw. I know Dean described initially 3.2. Sometimes it's 3.2, depends on how wide the slab is, but it's just a glide hole. Radiograph it, make sure you're across, and then a threaded hole beyond that, tap it, countersink, tap it, and put the screw in. So this is sort of AO technique, but done under arthroscopic guidance, and certainly a lot less morbidity. First of all, you get complete examination of your fracture. This is compared to arthrotomy, and you don't have the morbidity of the soft tissue damage. Everything's done through stab incisions like here. And a skyline radiograph can confirm the placement as well. I'll have another break, but just to show fractures of the front of both condyles, both facets. See here, this is just the radial facet. That's the most common one. But in racing quarter horses, and I've never figured out why, the usual slab fracture goes across both facets. So it's collapsing. The radial carpal bone's dropping in, and if you don't do surgical fixation, they gradually collapse into carpal varus and founder in the other leg. So this is a life-saving procedure, but it's still done arthroscopically because you can do a more complete job due to both visualization as well as lack of morbidity. So it's the same techniques. We put needles in. I generally have 2 spinal needles across, one across the radial facet, one across the intermediate. We can use the skyline radiograph to get our angle. We use the flexed radiograph to use our angle of our screw and that dimension. And then this is what we end up with. So time for more questions.
With soft tissue minimally invasive surgical procedures, we are generally prepared to convert to an open procedure. Does that ever happen with arthroscopy? And if so, an example?
No, I can't think of an example, but it used to in the early days. It all depends where you are on the learning curve. But I think it's extremely rare now, Christopher.
Yeah.
You know, I can't think of doing an arthrotomy. Now, one thing that happens in human orthopedics, it does happen. And it's kind of interesting because they always call it a miniarthrotomy, but some of them look pretty non-mini, if you know what I mean. And you've got an arthrotomy. And so, and certainly if you're getting into some of these reparative procedures, it's a really good question, because what's happening is with regenerative therapies, if you're injecting something, it's relatively straightforward. If you're putting stem cells in with PRP, which we have done, you can do that under arthroscopic guidance. However, if you have a scaffold, and of course there's quite a lot of tissue engineering being tinkered with, and where we've put implants in. We've done, most of ours have been all done experimentally in research horses, but then you've got a fairly big hole for your instrument. So on reflection, those would be instances where you could convert, but we're really staying away from implants yet. We've got a big research project going on a certain form of 3D printed construct loaded with stem cells. This is a project that I'm involved in with Tim Woodfield in New Zealand at the medical school in Christchurch, and Alison Aldridge, who is one of our residents, is a faculty member at Massey. It's her PhD work. And we've had quite a lot of challenges in putting those implants in. So we certainly have had arthrotomies as part of it.
Okay. This next question comes from someone who says, I know little about arthroscopy, but it seems that routine radiographs miss a lot that arthroscopy finds. Is that the same with CT?
Yes and no. We haven't advanced enough with CT to say that. We've done some comparative studies with arthroscopy and ultrasound. It depends on the joint. I'll use one example. With the majority of with femorotibial arthroscopy, which I've got at the end of the talk, the two main conditions are soft tissue injuries, which could be meniscus, cruciate, and subchondral bone cysts. Now, subchondral cystic lesions, they show up radiographically, but meniscal tears don't. And so the main workhorse diagnostic imaging technique is ultrasound. And when you've got people like, our specialist radiologists, they're good at it. And our sports medicine people, our boarded sports medicine people, the residents get a lot of training in ultrasound of joints. So I would say ultrasound mainly. CT is a good one because we've done some comparative work with CT, contrast CT in the joints, but we're not there yet. So but certainly MRI in the distal limb and ultrasound are very important pre-arthroscopy techniques.
Okay, that's it for this break.
Okay, so the last section, I wanted to show a little bit about condylar fractures because this is sort of the other great example of arthroscopically assisted repair making the difference. And again, it's going to be a combination of reduced morbidity, but also with no arthrotomy, but also more accurate diagnosis. And so what we do, we get condylar fractures as most people are involved with horses, as all people who are equine vets out there. They come in different shapes and sizes, but more importantly, displaced and non-displaced. And so this is an example of a displaced fracture. You can see the fracture line. This is the lateral condyle. This is merging onto the sagittal ridge of the distal metacarpus. P1's down here. And so the two things that we've got to achieve with these fractures are verification of articular alignment as well as compression of fracture being critical. And there's been studies now with arthroscopic repair. If you go back to the early days, Mark Rick, when he was a resident at Davis, published on arthrotomy. And of course, the success rate is significantly lower then, but it was the best we could do. And so we have improved our ability to treat them. So this is just an example of doing a incomplete condylar fracture. You can see we've got a gap, but we've got an intact strut up here. It's a combination, again, of arthroscopic examination and needle placement and radiographs for where we put the screws. And so we just do a glide hole across these ones. We don't have to reduce particularly. And so it's just lag screw fixation. In this case, there's two screws. And arthroscopically, we look in both the dorsal cavity. You can see here, this is the fracture line. very well reduced. And we also look in the back because this one is well reduced. There's blood clot coming there after I put the screw in. And the most critical thing is we're looking at the sesamoid bone. This is the lateral sesamoid. So this is this bone here, sorry. And if it's clean, that horse is going to race fine again. On the other hand, if we have a lot of erosion on that bone, and I'll show you an example of that, then we're in trouble. So this is reduction of a displaced fracture. We can do it with a combination of flexion, extension, and rotation. So we're looking at it arthroscopically. This is in the process of reducing it, and then we get it completely reduced. This is how it looks. And put a leg screw across, that's the same horse. But it is tricky. And so what we do is that we play with it until it's reduced, then we'll place reduction forceps on it. This is just a radiograph showing the screw, the glide hole crossing the fracture line. And then this is after completion. This horse required three leg screws. And then this is both dorsally and palmar, good reduction of the fracture site, and more importantly, good articular cartilage. So even though it was pretty ugly, it was displaced, that horse has a prognosis. On the other hand, has a good prognosis. This is another case. This is another horse where this horse had a displaced fracture, but this erosion on the cartilage was already there. Loss of articular cartilage changes the prognosis. So the last joint or area I thought would be good to talk about is arthroscopic surgery of the medial femorotibial joint. We do some in the lateral femorotibial joint, but mainly it's in the medial. And we talked about femoropatellar, where we get OCDs. And so the main injuries are subchondral cystic lesions in the medial femorotibial joint, and they occur in that should be medial femoral condyle, my apologies. Meniscal tears, cruciate tears. We get fractures of the intercondylar eminence of the tibia that are treated with removal. And many of these cases start as diagnostic arthroscopy. The typical referral I get with these is the horse has a problem behind, it blocks, ultrasound examination, and there's a big learning curve with ultrasound. I certainly don't consider myself competent at diagnostic arthroscopy of the stifle. We've got a lot of expertise here at CSU, and the expertise varies otherwise, other places. So, but there's a hint that there's a damage, for instance, in the meniscus. But the bottom line is back to the question that Christopher passed on before, you've got to go and look. And I should mention that Dave Frisbee developed a technique in the standing stifle with a very small arthroscope that has some flexibility to it, so it's not going to break standing, and you can get, for less expense without general anesthesia, get some idea if you need to do surgery, but it's very limited what you can do surgically. So then it's just a case of looking at it. It's starting to being used in doctors' offices, looking in your knee kind of thing, but it's still got a long way to go. But back to the point with femorotibial joints, the two main things I want to, is medial condyle of the femur, subchondral cystic lesions, the medial condyle of the femur. And so they typically are diagnosed radiographically, and then we've got a number of options. For a long time, we debrided the cystic lesions. We've now shown with nothing ruins results in long-term follow-up that we had a number of cases came back to us at CSU, and so we looked at all our cases and published it that after debridement of the cystic lesion, later on the horses would represent with a tear of the meniscus, and we concluded, or we have a hypothesis that we're pretty strong about, that the edges of bone sort of act like a cookie cutter on the meniscus below. And so we also did another big research project that Brigitte von Reckenberg, a Swiss veterinarian, did her PhD work in this, where we looked at the lining of normal subchondral cystic lesions after we had debrided them and shown that they had high levels of interleukin-1 and metallometalloproteases. So we hypothesized that if we injected corticosteroids into the cystic lining, we could treat them. And that's been our go-to method for quite some time. And so I'll just show you that intralesional injection of the subchondral cystic lesion. Now, if you inject intra-articularly, it doesn't get in there and it doesn't fix the horse. But on the other hand, if you go in there and make sure this is all you've got, sometimes you'll have an OCD flap associated with the cyst. So arthroscopy is good for that as well. And then we go in with a spinal needle and we inject up to 20 milligrams of triamcinolone acetonide into the lining. Sometimes we have to go in different places. Sometimes we have to slide down the edge of the cyst. But we've actually had a 90% success rate with unilateral cysts in that direction. Now, there's another technique that's getting a lot of traction, and this was developed by Dr. Liz Sanchi, who's at Kansas State, hypothesizing that if you put a lag screw across the cystic lesion, you could promote repair. And this has certainly, Liz has got good post-op data, and obviously it's more invasive. You've got to have a cystic lesion that comes up far enough that you can put your screw across. And so, like I did a case 2 weeks ago that the cystic lesion wasn't big enough, so I treated it with intralesional drugs. But this technique has become quite popular and is an interesting alternative. Now, medial meniscus tears, like initially the only ones that were diagnosed in the past were the huge bad ones, and the horses were crippled and commonly euthanized. The arthroscope allowed us to, but I do need to acknowledge the value of ultrasound exam has revolutionized our ability to treat these conditions, which aren't uncommon. They're quite common in particularly the working Western horse, like cutting horses, reining horses, Western cow horses, but we also see it in jumpers and dressage horses as well. And many of these can be treated successfully. Now, the bad news with the meniscus in the horse is that we have very limited views. We only see about 20% of it. We'll see 15% in front, the cranial horn. This is a view of a meniscal tear and the cranial horn of the medial meniscus. This is the medial condyle. This is the tibia. I've just sort of pulled it up with a probe, and then this is after debridement. If we completely debride it, it's a grade 2 tear. If it just involves the cranial ligament of the meniscus, it's a grade 1. And if it disappears, so you can't debride it all, it's a grade 3. And so, just by the way, because of that question previously, grade 3s have been agreed to by studies by John Walmsley, who formulated fixation in England, now retired, but a great equine surgeon in the UK for a long time, and Dean Richardson's group at New Bolton. Grade 3s just, you can't treat them. You won't get a sound athlete back. And we have been able to get sound athletes back in 60% of cases with following up with intra-articular injection of MSCs. But the important point here is that we put the scope in the front, in the cranial pouch, and then we also go in the back and put it in the caudal pouch of the medial femorotibial joint. So that's giving you a quick overview. Phase 3 of arthroscopic surgery, which, as I promised you, was my last slide, adjunctive therapies, particularly mesenchymal stem cells, but also IRAP, autologous conditioned serum. I have to leave for another evening, but if we've still got a time for questions, Christopher, or a couple of questions, that would be fine.
Yes, I've got a couple of nice questions here. One is, what would you consider the biggest development or developments over the years for equine arthroscopy, either instrumentation-wise or technique-wise?
I'd say technique-wise, but It's both. That's a quick answer. It's a really good question. And I have to confess, I've never talked about it. I've never thought about it before. As you saw when I went over instrumentation, the synovial resector, like basically, I can do a carpal chip fragment or a proximal dorsal P1 chip fragment without a motorized resector. But I would be very uncomfortable. I can't do a sesamoid fracture, a palmar, plantar P1, a stifle arthroscopy without a resector. So maybe I'm contradicting myself. But
do you remember? Yeah, well, it's both then, like you said, right?
Yeah, it's both.
Yeah. So when did those come about, those resectors? We didn't have them in the 70s, maybe that.
No, we didn't. Well, actually, Lanny Johnson, who I mentioned before, well, we didn't have anything in the 70s.
That's true.
Really. But, you know, we had good instruments in the 80s, but the first motorized resector was developed by the same guy, Lanny Johnson, that I mentioned, that I went to his course with. We had cameras were huge, obviously.
Yeah.
We didn't, like, I didn't get a camera till.
It didn't come till the 80s. Yeah.
Oh, mid 80s. Yeah.
Mid 80s, exactly.
Yeah, like I did surgery for 4 years without a camera.
Yeah.
And then after that, if I went to some, shall we say, out of the way place, I didn't have a camera either. So, but it was funny. It was funny because, you know, we were typically doing 8 horses a day at Los Alamitos once we got going, because the thoroughbred guys started sending their horses too. And so I'd feel quite beat up with 2 days of arthroscopic surgery looking through the scope, because you get into a lot of contortions that weren't normal. So I'd say camera, mid 80s, resector, a good resector, Christopher, late 80s.
Yeah.
So, yeah.
And last question, can you help us to understand the translational aspect of your research? I think this person's asking what's the meaning of translational and how does that apply practically to your research?
Good question, and I passed over it. I had a slide when I first showed that slide of Lanny Johnson going to the course with Lanny Johnson. What I put down there was, this is an example. This was my first example of translational therapy, and that was translating from human to equine, because it was going to that course that allowed me to then realize what we could do with the arthroscope, and that morphed into arthroscopic surgery. You know, I don't want to pretend that I was the only guy. I developed all the techniques. Obviously I didn't, but going to that course was really the start. So then on the other hand, as we've gone through life, so, you know, like if I talk about the phases of my career, just briefly, started doing tons of arthroscopic surgery. As we got deeper and deeper into arthroscopic surgery, and we did more joints and we did more conditions, we realized that we needed help. I had a slide which I took out because of the interest of time I like this little diagram of saying we found problems that we couldn't fix with arthroscopy. So then we went to the research lab. And so, you know, our orthopedic research center really started in the early 90s. And so we started, you know, doing arthroscopy. And then my first translation where we were doing something in the horse for the humans was when Dr. Richard Stedman was introduced to me by Bill Rodkey, who was a veterinarian, but also a small animal boarded surgeon, actually, but he'd worked in the military at the Letterman Institute, and he'd met Dr. Stedman. And then Dr. Stedman hired him when he retired from the military as his research officer. And they came up, and so he said, I want to get proof that microfracture, this technique for cartilage repair, works. And so Dick and I became close friends, and we did studies. We did 6 different studies on. We showed that we upregulated type 2 collagen levels, that it was very critical. One of our pivotal papers that's published in the American Journal of Sports Medicine, we showed that if you don't remove the calcified cartilage, And you have to really curette hard to get rid of the calcified cartilage. It's commonly left behind. And we left it behind accidentally in some early studies. And that was when we went to a controlled study of taking it out, that your repair is terrible. And so that paper led to MDs they used to clean all their defects with a resector, and they weren't getting all the calcified cartilage. And so that led to the recommendation that you need to curette the base of your defects in human. So that's an example. Now, as we've gone on, the horse is a great model for human knees because of the thickness of the cartilage being comparable, the fact that we could control the exercise, we could do everything arthroscopically. So we started doing some significant, being asked to partake in NIH level studies and also corporate studies for human use. So that's how we steadily went up the curve of translation. And then the Translational Medicine Institute is the result of us having enough techniques for horses and wanting to do more for humans, and convincing John and Leslie Malone that this was the thing to do. And that has led to the Translational Medicine Institute, which a lot of you haven't seen because we've been in COVID lockdown, but it's a fabulous facility that's allowing us to continue that beyond what we've been doing up till now. But it all really started with the combination of, initially our first translation was reversed from human to equine, but since then we've been steadily making more contributions for human. And a lot of our papers now are published in the human literature. So not bragging, but it's because of the team we got and the expertise we've built up. And then also our collaborators, because some of these really good, excellent researchers, Al Grzinski at MIT, Bob Sarr at UC San Diego, Steve Triple at Indiana University, Connie Chu at Stanford, they've all come and done projects with us. And, Dave Frisbee, myself, Laurie Goodrich, Chris Kalchak, we've done a lot in our team. We've just had a lot of studies. And so it's good to put back, plus at the risk of stating the obvious, if there's got human value as well, then we get a lot more support for it. So we can help the horse by providing translatable stuff. We have one strict criterion, though. We will not do research using horses if it's not potentially valuable. Whatever we're looking at is potentially valuable to the horse.
Great. Thank you very much for this fantastic overview, Wayne. Much appreciated. It was a great talk, I think. Once again, I'd like to thank all of you in the audience for joining us. Next week, we'll hear from Dr. Brian Evans in San Diego, California. Dr. Evans is a small animal practitioner who will present some very valuable data based on his experience developing a profitable practice, a startup practice centered around rigid endoscopy, specifically the laparoscopic spay and video otoscopy in dogs and cats. So if you're at all concerned about maximizing the return on your investment in rigid endoscopy, this will be a must-see webinar for you. That's next Wednesday, October 28th at 2 p.m. New York time. And remember, any past talks can be viewed free online at endoscopytalks.com. Wishing you all well in your practices and, of course, the best of health during these challenging times. Look forward to seeing you next week. Thank you.